Mr. Walker, it is a great pleasure to once again serve under your chairmanship, and I would like to pay particular tribute to other honourable members who have joined me on the new Blood Cancer All-Party Parliamentary Group, and particularly to the honourable member, the gentleman for Strangford, for going to the Backbench Business Committee and asking for this debate, and therefore my appreciation also to the Backbench Business Committee for allocating time today to discuss this very important issue. The honourable member for Strangford is an assiduous parliamentarian, and I think we are very grateful to have his wise words and his commitment behind this important issue. I know that many of my own constituents have seen firsthand through family and friends the real-life effects of blood cancer, and I think we heard a very powerful, very personal as well, presentation just a few moments ago. For my own part, almost exactly 4 years ago this month, my mother passed away from acute myeloid leukemia. So I know that the many personal stories that will be in the public gallery and beyond as well is something that I think is important to ensure that this issue is highlighted. This morning I was very pleased to see that the National Institute for Clinical Excellence, NICE, has approved the chronic myeloid leukemia drug bosutinib, and this is of course great news for patients, and I certainly hope that this will not be the last such approval in the weeks and months to come. But Mr. Walker, not least because by 2020 almost half of the UK population will receive a cancer diagnosis throughout the course of their lifetime, as we have previously been discussing. The importance of early diagnosis cannot be underestimated. Well, I'm sure that everyone in this place is aware. It may come as a surprise to those who are not so familiar with this issue that blood cancer is the third biggest cancer killer and is in fact made up of over 130 different diseases, including leukemia, lymphoma and myeloma. It's important, Mr. Walker, not to lose sight of the importance of ensuring emotional support. The way the Cancer Drugs Fund list of medicines was managed in 2015 provided additional emotional strain on some patients, their families and their support networks. Several treatments were not approved by NICE, so they were unavailable to patients. Some were made available through the Cancer Drugs Fund. However, 16 of these indications were then delisted, as again we have heard earlier on, during 2015, and 2 of the delisted medicines were reinstated onto the CDF in October last year after NHS England and the drug manufacturers agreed a new price. All treatments currently on the CDF, or those that were delisted, will be reviewed by NICE in the coming months as part of the new system for appraising cancer drugs. And this could mean the current status of these drugs could change once again, providing additional uncertainty. This is, of course, welcome if it ensures that drugs end up becoming available, but the lack of permanency in such decisions is, of course, distressing for patients and those who care for them. For someone on a first-line treatment, not knowing if the second or third-line options would be available, or worse, knowing that they would not be, would place them in, and family members in an almost unthinkable and unbearable situation. Mr. Walker, the real concern is that while the revised Cancer Drug Fund provides interim funding for a drug of up to 2 years, is this time enough to secure the necessary data needed to make a final decision? As for my work in helping to form the new Blood Cancers APPG, I have been made aware of a number of concerns regarding the new Cancer Drugs Fund system. Firstly, the difference in the new incarnation of the CDF has actually led to confusion amongst patients. Whilst the old system provided a safety net for patients if a drug was delisted by NICE, in the new system, a negative verdict from NICE means that there is no remaining safety net and the drug will be unavailable to patients. This is, of course, a significant cause of concern. Secondly, the way in which the fund operated allowed a number of drugs to be provided to NHS patients that previously would not have been provided. Many of the CDF drugs have previously been turned down by NICE, either on the grounds of being too expensive or by having insufficient data due to the small patient populations they were targeted at, or by low patient numbers making it impossible for cost effectiveness to be assessed using NICE's standard methodology. Thirdly, treatments currently on the CDF and those that were previously included but subsequently delisted will all be reviewed by NICE under the new system. As I mentioned earlier in my remarks, it is the instability which also causes suffering. Where patient populations are small, it can be difficult to secure the necessary data to provide a successful application to NICE. Fourthly, the success or failure of the new process will depend on how NICE interacts with the pharmaceutical industry. Both sides have a crucial part to play, and flexibility is required on issues such as pricing, access schemes, the application of methodology, and how clinical data is used. Fifth, and finally, Mr. Walker, the revised CDF will provide interim funding for a drug of a maximum of 2 years if NICE deem that further clinical data is required before a final appraisal decision can be made. The new CDF will therefore provide temporary funds whilst data is collected, whereupon the drug will be approved or declined by NICE. This fund is welcome in principle, but for some of the blood cancer drugs in particular, due to be reviewed by NICE, an additional 2 years will not be sufficient, I fear, to secure the necessary data to make a final decision. The UK, Mr. Walker, is a world leader in blood cancer research, and that, of course, is to be welcomed. And as a country, we can be proud, I think, of the work that we have done, whilst recognising, of course, that there is still much more to do. Work undertaken in this country has improved our understanding of blood cancer and has helped lead to a number of life-saving and life-changing treatments, which are now available with many more in process. Blood cancer research in the UK has been at the forefront of advancing precision medicine for patients, from molecular diagnostics to targeted therapies. In launching the APPG, it has been a pleasure to work alongside charities such as Bloodwise, who have, since their launch in 1960, spent over £500 million on research into blood cancer. And I particularly today would like to pay tribute to the work they have done and continue to do. The UK's world-leading blood cancer research not only helps those affected by blood cancer, but the research also allows a greater understanding of other cancers as well, and has helped develop new treatments for other diseases. It is vital that patients are able to benefit from the research being undertaken, and I would like Mr. Walker to ask the Minister for his views on providing a new model for appraising cancer drugs. Along with the work of the government's Accelerated Access Review, this provides a long-term and sustainable system for patients to benefit from the innovative life-saving drugs being developed. Last month, I received an answer from the Minister of Public Health, my honourable friend, the member for Battersea, to a written parliamentary question where the Minister referred to the government's announcement in September last year that by 2020, the approximate 280,000 people diagnosed with cancer every year will benefit from a tailored recovery package. And so therefore, I would also be grateful if my honourable friend here today might be able to provide an update on this goal. In closing, Mr. Walker, I would also be grateful for reassurance on the following issues. that the new process for reviewing medicines will enable blood cancer patients to access the drugs that they need, that consideration will be given to to rare diseases and drugs targeted at small patient populations, with clear guidance given as to how they will provide a fair assessment of such drugs,